Hello, and thank you for inviting me to talk at this virtual SMRA 2020 session. My name is Nick Burris. I'm a cardiothoracic radiologist at University of Michigan, and in this talk I'm going to review a clinical perspective of some current and emerging applications of 40-flow MRI. So to start off, I'm briefly going to review some characteristics of what makes for a good clinical application of an imaging test. And then I'm going to review a handful of current and emerging applications of 40-flow MRI. This won't be exhaustive, but these will be some emerging applications that I think are particularly good reflection of the fact that abnormal blood flow leads to pathology in a variety of vascular, aortic, and cardiac diseases. And then lastly, I'm going to talk about some barriers to translation in clinical application. So this is clearly a bit of a joke here, but the point that I think is relevant is that we have the ability to use a lot of very advanced technologies, 40-flow MRI being one of them, but we need to have a very clear understanding of what this advanced technology does for the patient and where it very clearly intersects with current clinical care pathways for it to be a good clinical application. So here I'm going to briefly review some characteristics of the technology itself and the clinical application that would be optimal for clinical translation. And this is taken from some literature on technology diffusion, kind of more broadly speaking. So characteristics of the advanced imaging technology that would be important include reasonable scan times. This is relevant for both money to the hospital and patient throughput and also patient comfort. The scan or the technology has to be not that hard to use. It has to be easy to set up and get started using. It has to have a reasonable number of parameters and settings that can be prescribed by someone with a reasonably minimal amount of training. The post-processing has to be manageable. This has been challenging with 40-flow for many years, but we've made a lot of headway in that space with some of the new commercial products. These output itself has to be reasonably reproducible, inter-rater and inter-scanner. Clearly other imaging technologies suffer from this too, but you do need to demonstrate some degree of reproducibility of your values. And then looking at the clinical applications, this technology has to have a significant relative advantage over the existing technique. So if the existing technique is echocardiography, you have to show that you can do something better or faster or more accurately. The results of this test need to be actionable. They need to inform a clinically important diagnosis or treatment decision. If it's just information for the sake of information, it's going to hinder translation. They need to be relatively easy to interpret the measurements. If your key variable is some third-order derivative, it's going to be hard for the average person receiving the result to interpret. And lastly, and this usually comes much later in the translation pathway, but showing that the technology itself is cost-effective is always a very important final step. So there are several characteristics of 40-flow that make it an attractive clinical tool. Number one, it can deal with complex flows and complex anatomies. It's plane independent, so you can retrospectively interrogate a full volumetric flow data set in arbitrary planes as needed. It can yield advanced hemodynamic parameters like kinetic energy and wall shear stress, and it actually can be applied to a lot of different pathologies in both the brain and the aorta and the heart that are already indicated to undergo clinical MRI, so the patient is already on the scanner. So as a brief outline of what we're going to review, we're first going to discuss aortic disease, specifically aortic valve disease and aortic stenosis, and then we're going to turn to some aortic diseases, including valve-related aortic disease, specifically related to bicuspid aortic valve, and then aortic dissection, and finally we'll turn to the cardiac space and look at quantification of mitral regurgitation and stasis mapping in atrial fibrillation. So turning to aortic stenosis, what's the clinical problem? Well, aortic stenosis is a disease characterized by progressive thickening and calcification of the aortic valve leaflets that occurs over a period of decades, and that eventually leads to significant pressure gradients across the aortic valve and LV pressure overload. Patients are relatively asymptomatic for a large part of the disease course, but once symptoms develop, their mortality really quickly drops off the cliff here, and they need reasonably urgent surgical intervention. The severity of aortic stenosis is currently graded using echocardiography, and this presents a clinical problem because the echocardiography results in discordant grading in approximately 20 to 40% of cases. This is important for clinical management because patients with moderate aortic stenosis undergo medical therapy, and patients with severe aortic stenosis are indicated to undergo surgical or transcatheter aortic valve replacement. So how can 4D-Flow help in this instance? Well, it can help overcome some of the limitations, the technical limitations of echocardiography that lead to these discordant gratings. Number one of including bad imaging windows. Echo is dependent on getting the right plane of insonation, which in patients with large body habitus and other anatomical reasons can present problems. It can capture the jet in a completely orthogonal plane and not have issues of oblique or off-axis jet angulation. And we don't use 2D phase contrast for aortic valve stenosis, but clearly the three-dimensional nature of 4D-Flow acquisition can help find the peak velocity more reliably than we could in a two-dimensional imaging plane. So turning to some recent results that demonstrate how 4D-Flow MRI could be useful in the assessment of aortic stenosis, there's a recent paper in SMRA in 2019 that very nicely showed that the degree of eccentricity of the systolic flow jet in the ascending aorta correlated very strongly with the measured differences in the peak velocity between 4D-Flow MRI and echo, suggesting that the more eccentric the jet, the higher degree of discrepancy that occurs in the peak velocity measurement. This suggests that if 4D-Flow is better able to capture the true peak velocity, this may result in a more accurate assessment of the true stenosis severity. In addition, 4D-Flow MRI can be used to quantify energy loss in the form of turbulent kinetic energy or viscous energy loss. And this energy loss can be really helpful, potentially, in the clinical setting to help better understand the deleterious effects of stenosis on the ventricle, as this energy loss represents an additional burden for the left ventricle to overcome in aortic stenosis. So now going upstream from the aortic valve, we have the problem of ascending aortic dilation or aneurysm, which is frequently seen in association with patients who have aortic stenosis due to the post-stenotic flow jet impacting the ascending aortic wall. This is particularly true in patients with bicuspid aortic valve that experience approximately a 50% lifetime risk of developing an aneurysm. And so how can 4D-Flow help in this disease? Well, certainly 4D-Flow has been shown very clearly to be able to be used to quantify the degree of flow abnormality in the ascending aorta. This abnormal flow imparts abnormal shear stresses on the ascending aorta, and ideally these shear stresses, through their known relationship with aortic wall remodeling, can be used to predict growth. So 4D-Flow has been used pretty extensively to demonstrate that there are very unique and significant hemodynamic abnormalities in bicuspid valve patients relative to healthy patients. This has similarly been shown with two-dimensional phase contrast imaging. However, really to fully appreciate the three-dimensional flow abnormalities and to calculate wall shear stress, 4D-Flow is really critical. There's a variety of different approaches to quantify the degree of flow eccentricity in the ascending aorta, and 4D-Flow plays a significant role in a lot of these calculations. A potentially very interesting and clinically relevant application of wall shear stress mapping using 4D-Flow MRI would be identifying tissue at risk maps, as shown below here, that could be used in patients who are being considered for aneurysm repair to help identify tissue at the greatest risk of dissection and future disease progression, to allow for selective surgical repair strategies that remove the maximum amount of unhealthy tissue. Now turning to aortic dissection, which is a topic that I have a lot of research interest in. What's the clinical problem? Well, patients that develop dissection and then have this false channel running in their aortic wall live with these dissections chronically. They can be medically managed, but medical management fails at a pretty high rate and patients progress to aneurysm. Surgical repair is effective, but has to be performed at appropriate times and comes with costs and complications. Well, how can 4D-Flow help? Well, it can identify abnormal hemodynamics in the false lumen in particular that suggest high degrees of pressure and other abnormality, and could identify patients at high risk of progression and complications and inform endovascular. So specifically, a parameter that can be used to estimate risk of future growth in the false lumen is a parameter that we've termed false lumen ejection fraction, and this is simply the ratio of retrograde flow leaving the false lumen during diastole over the antegrade flow into the false lumen during systole. We've shown in some preliminary data that this can predict risk of future growth and aneurysm formation. And then in addition, 4D flow is exquisitely good at depicting the actual communications between the true and false lumen because of these high velocity jets that form between the two chambers. So when the goal is occluding these jets during endovascular repair, 4D flow is an excellent tool to identify all of these communications during surgical planning. So now turning to the heart, one of the valvular lesions that is most difficult to evaluate with echocardiography is mitral regurgitation. And echo is known to underestimate the total regurgitant fraction. And this is largely due in part to the fact that the mitral valve and its subvalvular apparatuses is kind of a complex mechanism, and it results, as you can see here, in eccentric jets that can be single or multiple, and so it can be very hard to fully capture the full regurgitant volume. So how can 4D flow help? Well, it kind of seems intuitive, but it's a volumetric coverage, so you don't have the plane dependence of the measurements, and you should be able to see all of the jets and measure them in a quantitative fashion. So one approach that's been described to assessing mitral regurgitation volume is not using 4D flow actually, but is an indirect method that uses the stroke volume as calculated by short axis cine SSFP, and the aortic forward flow, or the stroke volume, as calculated by two-dimensional phase contrast, and then subtracting the two to find the regurgitant volume. This method has some advantages. It has been shown to have prognostic significance, but there's still a desire to be more precise and more reproducible and to directly measure the jet, and 4D flow is a technique that affords the opportunity to do that. So there's ongoing work to use 4D flow in directly quantifying mitral regurgitation. One of the challenges is that the mitral valve moves between the base and the apex of the heart quite substantially during the cardiac cycle. So valve tracking techniques have been developed to follow the movement of the valve throughout the cardiac cycle and track the regurgitant jets over that time. And this approach has been shown to improve the measurement, reproducibility, and accuracy. Another emerging application of 4D flow in the intracardiac space is the assessment of atrial fibrillation. Atrial fibrillation is a disease characterized by an abnormal rhythm of the left atrium, which prevents normal left atrial contraction and leads to stasis and potential clot formation in the left atrium. That clot can embolize into the body and cause stroke. There's a variety of treatments for atrial fibrillation, but one of the most common is to put patient on anticoagulation medications, which thin the blood and prevent thrombus from forming. However, these medications come with a lot of side effects and can cause abnormal bleeding. So it would be ideal if 4D flow could provide us with a direct quantification of the blood flow in the left atrium to help better understand which patients are at highest risk of forming clot and those that would then most benefit from surgical treatments or anticoagulation. There's a variety of metrics that have been described, most of which focus on quantifying static blood within the left atrium, and clear differences between healthy volunteers and those with more severe degrees of left atrial fibrillation have been demonstrated. So to summarize here, what is really needed for clinical translation of 4D flow MRI? Well, first and most importantly, there need to be clear research targets and collaborative efforts involving large multi-center studies. As we mentioned in the beginning, any test, including 4D flow MRI, needs to show significant relative advantage over existing techniques and demonstrate or give results that are actionable. And one of the best ways to do this is through large multi-center studies. In addition, we need to think about correlating 4D flow metrics with clinically meaningful outcomes that extend just beyond mortality, but even things maybe that are less typically studied but show value, such as procedural time, technical success rate, complications, cost, etc. Of course, a prerequisite to all of this is that we have widely available standardized sequences that are relatively fast from all the different MRI vendors, and also some standardized analysis softwares. This has been a significant challenge, but we need to continue to push towards reproducible measurements. and limited numbers of parameters that need to be adjusted by technologists and clinicians who are operating the sequence. And then finally, since 40 flow MRI is a kind of a newcomer and there are a lot of existing techniques, I think an important but sometimes overlooked feature is cost effectiveness. This can be very hard to actually study and establish, but I think it's something that we should think about addressing more. Does 40 flow MRI save time or money? Does it add value? Obviously time and money are highly linked with MRI, so the more that we can show value added and decrease downstream costs associated with 40 flow MRI acquisitions, the more likely this technique is to translate into clinical practice. So with that, I'm going to wrap up. Thank you for listening to this recording, and I will be on the session to answer any questions, and I look forward to hearing from you. Thanks.